Hello, and welcome to this CancerLinQ video podcast interview. This is Dr. Bob Miller, Chief Medical Science Officer for CancerLinQ. CancerLinQ is a health technology platform developed and implemented by ASCO, focused on improving the quality of care and health outcomes for all patients with cancer and advancing evidence-based research. Today, I'm pleased to have with me Dr. Emily Ray from UNC, the first author of a paper that was published August 10th, 2022 in the journal JCO Oncology Practice, entitled Incidence of SARS-CoV-2 and Subsequent Mortality in a Multi-Site Cohort of Patients with Cancer in the CancerLinQ Discovery Database. We will put a link to the paper in the notes for this YouTube video. Dr. Ray will more formally introduce herself in a moment, but for transparency, I did want to add that I am a co-author on this paper. I have no other conflicts of interest other than being an employee of ASCO. So thank you, Dr. Ray, for joining me today. Please go ahead and introduce yourself.
Thank you so much for the invitation, Dr. Miller. So I'm a medical oncologist and a cancer outcomes researcher at UNC at the Lineberger Comprehensive Cancer Center. And my research interest includes the use of big data to look at outcomes for patients with cancer. And I'm especially interested in how to use electronic health record-derived databases to answer these questions. I do receive research support from Pfizer and Optum Health, but I have no other disclosures to report.
Great. Thank you for mentioning your COI. So tell me a little bit about this paper, why you and your co-authors were interested in the topic and what sort of prompted you to investigate this.
Sure. So, of course, the COVID pandemic has devastated our communities and our healthcare systems in so many ways. And we felt it's important to study the impact of COVID-19 on patients with cancer. And we thought this would be important as many questions still exist about how public health strategies should address the specific needs of cancer patients and how we should approach the clinical care of our cancer patients. And so as we thought about this question and we thought about the available resource of CancerLinQ Discovery, we felt like CancerLinQ was ideally suited to answer some of the questions about how cancer patients may or may not be at increased risk for SARS-CoV-2, and then what is the subsequent mortality for cancer patients who are diagnosed with COVID. And we felt like CancerLinQ had some advantages maybe over existing administrative claims databases and over registries in this context.
Okay. Can you describe the CancerLinQ Discovery Database a little bit more that was used for this analysis, and talk a little bit about the cohorts that were in the paper?
Sure. So CancerLinQ is a convenient sample derived from a wide diversity of cancer oncology practices across the U.S. When we did the analysis, there were about 3.5 million patients in the database. My understanding is that it's now blossomed to include over 6 million patients. And the database is derived from electronic health records of these oncology practices. And so you have longitudinal clinical data from cancer patients from these electronic health records, as well as some other data sources like cancer registry files. And so, kind of getting back to why CancerLinQ for this particular study, we felt like there were some advantages over administrative claims data, which of course can give you very large number of patients, but don't give you the rich clinical data that you can get from an EHR-derived data set like CancerLinQ. We also liked that CancerLinQ is inclusive of diverse clinical practices. And so we're not just looking at a single institution or a single state, but we're looking at cancer patients from a lot of different contexts. So we thought that was an advantage. The other nice thing about CancerLinQ is that we do have this rich clinical information. And so things like test results are available to us. So in a claims set, you might be able to see that a patient with cancer was tested for COVID, but you can't see what their actual test results were. And so we felt like the availability of those data in CancerLinQ was advantageous and sort of well suited to answer this question of what are the risks amongst cancer patients for SARS-CoV-2, and then what are the risks for subsequent death.
And can you talk a little bit about the cohorts that were in the paper? It looked like you looked at the main cohort of cancer patients as well as those that were tested or positive for COVID.
Yes, thank you for asking about that. So within CancerLinQ, we were able to identify patients who either had prevalent or incident cancer cases, and we looked at a study period of January 2020 through January 2021. And so our base cancer cohort included patients with a cancer diagnosis, and they had to have at least 2 clinical encounters in the 12 months prior to the study period. We wanted to make sure that we had some evidence of ongoing follow-up with their cancer team. And so we only included patients from centers that had at least 1 report of a SARS-CoV-2 test result. And then from this base cancer cohort that we created, we then identified a sub-cohort of patients who had a SARS-CoV-2 case. And they could have entered that sub-cohort either through a positive SARS-CoV-2 antigen test, a positive PCR test, or an ICD-10 diagnosis code for SARS-CoV-2.
Okay. And then what variables did you look at? I assume it was like demographics and certain clinical type things.
Yes, that's exactly right. So we looked at age, sex, race, ethnicity, and then we also looked at malignancy type and recent receipt of chemotherapy or other myelosuppressive therapy. And then we calculated unadjusted and adjusted incidence rate ratios and stratified these by clinical and demographic characteristics for both incidence of SARS-CoV-2 and for 60-day all-cause mortality within the subcohort of patients who had a SARS-CoV-2 infection.
Okay. So what were the findings? What did you find?
Well, so again, we had the kind of good fortune of large numbers. So the cancer cohort, that base cohort included 629,000 plus patients. And then we identified a subcohort of 12,300 patients who had a SARS-CoV-2 diagnosis. And the key findings were that we saw a higher incidence of SARS-CoV-2 infection among patients who were male, who were Black, Hispanic, under the age of 50, had a hematologic malignancy, or had recently received chemotherapy. And then we performed adjusted analyses and saw that the higher incidence in patients who were male, Hispanic, or had recent chemotherapy persisted. Okay. And then when we looked at all-cause mortality, there were 182 all-cause deaths within the SARS-CoV-2 cohort. So pretty low death rate amongst those who had had an infection. And when we looked at risk factors for death, we saw a higher all-cause mortality in patients who were male, had an unknown race or ethnicity, were age 60 or older, or had recently received chemo. And then again, we performed adjusted analyses and saw higher mortality with older patients over age 60 and receipt of chemotherapy.
So I know you can't tell this from the data, but the question is why? I mean, why do you think there was a differential impact of age on, it sounds like both on incidence and mortality?
Yeah, so we talked about this as a study team, and we think the increased incidence among younger patients under the age of 50, could be related to their role in the workforce, caregiving responsibilities, both of which would increase potential exposures to SARS-CoV-2, especially in the early phase of the pandemic when a lot of other people may have been more isolated. These are the people who were needing to leave their homes to go to work or provide caregiving. And then thinking about the increased risk of incidence and mortality amongst older patients, we saw the highest risk amongst patients aged above 80. And so perhaps those are patients who are, of course, have higher comorbid illness, but also may be more likely to live in a congregate setting or have caregivers coming into their home that would have increased their exposure. So, these are just hypotheses. I think it's worth noting that in CancerLinQ, we're unable to measure things like household or occupational exposures, but I certainly think this is an area of further investigation. And, these are the questions that I think matter to our patients. Can I keep working in my job, or is that too high risk? Can I see my grandchildren? Is that too high risk? So I'm hoping there's someone out there listening who's going to take that on using different methodologies.
Absolutely, yeah. How about, can you talk about the impact of race and ethnicity? You had some interesting findings there.
Yeah, so we did see a higher incidence of infections in patients who are Black or Hispanic, but not a higher risk of death. And so this mirrors findings of some other studies, including those in the general population, demonstrating that these racial and ethnic groups are at higher risk of infection. And so as we think about that, our study team wanted to acknowledge the underlying causes of these health disparities, which are complex, but do include factors related to structural racism, such as disproportionate comorbidities, disproportionate access to healthcare, and even household and occupational conditions that are different.
Okay. How about clinical factors like tumor and therapeutics? Was that, I think you found some things related to both incidence and mortality there.
Yes, we did see that there was increased incidence amongst patients with hematologic malignancies, although it's worth noting that the magnitude of this increased incidence was rather small and did not persist in the adjusted analysis. But there was a clear adverse impact of myelosuppressive therapy seen for both incidence of SARS-CoV-2 and subsequent mortality, even after adjustment for other analyses, variables. So, I think while the risk of death in the 60 days following an infection was generally low, it does seem that patients who are receiving these myelosuppressive cancer treatments is in fact higher. And so this, I think is worth considering when thinking about public health strategies and clinical care, thinking about this group of patients, which may be appropriate for prioritization of protective measures, vaccinations, boosters, pre-exposure prophylaxis, and now antiviral treatments that are available. Just thinking about how can we try to lower the risk of serious illness and death in this higher risk group.
And I should have clarified this earlier, but you were looking at all-cause mortality, right? You didn't have a way of teasing out what was death due to COVID versus cancer or comorbidities.
That's right. So we don't really have a way of teasing that out within the CancerLinQ database. And so we can't be certain whether the deaths in the 60 days following a SARS-CoV-2 infection are related to that infection or related to the patient's underlying cancer or something different entirely.
Okay. Yeah, that makes sense. So talk a little bit about some of the limitations of the study that you found. You had a few things that you mentioned in the discussion, I know.
Yes, and so that all-cause mortality was one of them. We tried to address that limitation by keeping the time window for that outcome fairly narrow, limiting it just to the 60 days. I think some other limitations to point out, this is not a population-based study, and so we can only see the data from patients whose oncology practices are participating in CancerLinQ. So there's potentially a bias towards larger cancer centers, integrated health systems where the testing results from SARS-CoV-2 testing are more likely to appear in the data set. And then kind of along that line, the testing data in CancerLinQ are not complete. So we know that there are cancer patients who might have been tested for COVID outside of the systems that feed into CancerLinQ, whether it's a pharmacy or a health department. And so we're not able to see those test results in our system. I think the other thing is that we know, as we were discussing before, that there are residual confounders like household and occupational contacts, as well as clinical information that are missing in CancerLinQ. Things like stage, which is not very well represented in most EHR databases. All of those things may be residual confounders that impact our outcomes of interest and could not be studied here.
And I would think the other thing is this doesn't reflect home testing. I think this was done earlier in the pandemic, so maybe it wasn't as prevalent then, or it wasn't prevalent at all at the beginning of the pandemic, of course. But I believe you just looked at the test that you could verify as having been done in a laboratory. Is that correct?
That's right, and the study period that's represented here really kind of predated at least widespread use of home testing. So I think that sort of underscores the importance of going back and actually looking at an extended study period that would be inclusive of home testing, the era of vaccines, which much of this time was before that, and see how these risk factors might have changed.
Yeah. So we're now, what, 2.5 years into the pandemic, something like that, lose track. What do you think are the implications of this study for patients today in the current phase of the pandemic?
So I think our study highlights that patients who are undergoing myelosuppressive cancer treatments are at increased risk of acquiring COVID and at increased risk of having COVID-related or perhaps COVID-related mortality. And so I think, I hope that our study will spark further inquiry about how to best protect these patients through prospective studies of different interventions like pre-exposure prophylaxis and antivirals, because we know these patients are having to balance the competing risks of their cancer. They need these myelosuppressive therapies and the competing risks related to COVID. And I also hope that our study, which like others has identified increased risks among Black and Hispanic patients, will maybe shine a light on the need to address these issues, these disparities in health outcomes.
Those are some great thoughts. Any final words for the readers of the study?
Sure. So first, I wanted to acknowledge and thank the co-authors on this paper, Danielle Potter, Mark Riffon, and Sarisha Kakamata, who did outstanding work on this study and were a real pleasure to work with. I'll also note that I think our work here is not done. As I mentioned earlier, the pandemic continues with new emergent variants, and I think we need to further investigate risk factors among cancer patients in that context. I think we know there have unfortunately been many more COVID cases since our study period, and we need to examine how these risk factors might have changed over time.
Sure.
I think there's also, Dr. Miller, some interest in looking at things like specific cancer types and specific treatments for different cancer types, and see how those different cancers or within a tumor type, how those COVID-19 risk factors may change. And, an example would be in breast oncology. I think we've wondered the degree to which CDK4/6 inhibitors might impact the risk of COVID infection, and is it to the same degree as cytotoxic chemo?
Sure.
So I think there's an opportunity to kind of zoom in and look at specific tumor types and specific treatments and try to get a little bit more granular information about risk. And I think CancerLinQ is well suited to further explore those questions. So I hope you'll be hearing more from our study team about that work.
Well, these are some great ideas for future research. I just want to thank you, Dr. Ray, for spending time with me today and for sharing your insights about your paper. And as a reminder, links to all CancerLinQ related publications, including this paper, can be found at www.cancerlinq.org/scientific-publications. And as I mentioned, the link to this paper also appears in the notes for this podcast. And thank you to the audience for your attention.